welcome all of you this morning to our first NP Educators webinar. I'm so very pleased to introduce my colleague, Dr. Tammy O'Rourke, who will be our presenter this morning. Tammy is likely well known to many of you. She has been a leader in nurse practitioner service and education, leading the NP clinics in Ontario between 2010 and 2014. And she has been very active in securing funding to support both the implementation and the sustainability of many NP-led initiatives, period. Here in Edmonton at the Faculty of Nursing, she has been our leader in a collaborative community care, C3 for Seniors clinic, which is a clinic funded through Alberta Health Services. It is an academic faculty practice clinic that is unique in Canada for NP practice and NP faculty. She is one of our leaders in NP education here at the Faculty of Nursing. And this morning she's going to talk about her research program in interprofessional team development in primary care, but most particularly her focus will be on the Canadian nurse practitioner workforce data and developing a standardized tool for data collection. So Tammy, please go ahead. We're all interested in your topic.
Thank you for that introduction, Dr. Hunter. It is a privilege to be here today to talk about Canadian NP workforce data and the work that myself and the associates listed on the slide have been doing for many years, actually, because we're going to talk about the historical collection of NP workforce data and how that all evolved in this province, and future vision for the collection of this data. And I'm hoping that the end of the presentation will lead to some fruitful discussion in terms of understanding educators' needs for NP workforce data to influence curriculum and updating NP course loads. So as you can see, I have been working with several individuals across the country, Manitoba, Saskatchewan, New Brunswick, and I see that Sharon's on the call, so I'm glad to see her here. Nova Scotia and Ontario and BC. There has been a lot of work done in Canada to collect data on NP workforce data, and I see Wanda might be having a bit of an issue with the volume, so I'm not sure if someone could check that for her. Is everyone else hearing me okay? It's hard because I can't hear anybody. It's like I'm talking to myself. So through today's discussion, we are going to talk about the history of the Canadian NP workforce data collection activities that have occurred, identify current sources of NP workforce data, understand the need to develop new measures for NP workforce data, and share categories and items under consideration for the development of a standardized NP workforce data tool. So let's start with why this is important. And I recently read a scoping review that was published out of the U.S. from a roundtable discussion they had. And this is a quote from that paper. Comprehensive and accessible NP workforce data are necessary for studying NP contributions to high-quality patient care and outcomes. And this has remained true for an extensive period of time, and I assume that it will remain true for many years to come, because it seems that we have to keep proving ourselves over and over and over again to decision makers. And a piece of that has been our journey to understand how, where, why, and when NPs provide services in Canada. So right now there are many sources of data. So one might say, well, why do we need a standardized tool? But I'm going to get to that in a minute. We have the CCRNR, which I think their most recent study, and Kathleen can probably correct me on this, and potentially Deb, who were involved in this, was in 2016. CAI, of course, collects numerous data on nursing, with NPs being a part of that data set. Provincial regulators collect NP workforce data, and independent researchers or collaborative partnerships initiatives also collect information on Canadian NP workforce. So what a group and I have been doing for the past, I'll probably say almost a year and a half, it's been a long process, is that we have been meeting quite frequently, and Sharon is one of those members, quite frequently via Zoom to discuss the previous instruments that have been used to evaluate NP workforce data. So we're really trying to develop an NP workforce data collection tool for the following three purposes. One, to provide foundational knowledge about the NP role that is contextually relevant. Two, to be sensitive to changes in scope of practice, because the last 10 years have seen us increase our scope of practice dramatically. And to be flexible enough to meet the needs of a variety of audiences, including patients, system leaders, decision makers, funders, that list goes on. So the working group has been looking at a variety of tools that have been used in the past, and I'll talk about each of those tools. And we have found that there were over 150 instruments to measure the work of advanced practice nurses. 23 of these are specific to NP practice, but no one survey has emerged as the gold standard. And we haven't published a survey in Canada or internationally to meet the needs of the collecting NP workforce data in some standardized way. And there are large discrepancies in the validity, reliability, and indicators reported for NP practice patterns in Canada and abroad. There's a lot of, there's so much variability in terms of what we've been collecting and how we've been collecting it. The first attempt, or first, let's say, kick at the can, to measure NP workforce data, and I'm sure everyone is familiar with this, is the Spitzer article, right? The Burlington randomized trial of the nurse practitioner that dates back to 1974. This was sort of the inaugural attempt to collect information about how, why, and where NPs worked. And they used data from three sources: day sheets, which included information about the patient encounters, physician observations about NP work, and the nurse activity observation form, which allowed observers to provide details about the NP work in primary care. Since that time, we've moved on to several other sources, including the also well-known IBM report out of Ontario. And the Nurse Practitioner Practice Pattern Survey work was first conceptualized in this province because they came out with the largest number of NPs first, I guess, let's say. And it was Alba DiCenzo's team at McMaster who were commissioned to complete a needs assessment examining the potential for NP integration in Ontario. The IBM study came out of this work. The first survey of NP work in Ontario included 85 items to collect information about NP demographics, workplace activities, and workplace satisfaction. It was a paper-based mail-out that was sent to potential respondents by the College of Nurses of Ontario. Next came another survey out of Ontario, which was the survey of Oncology Advanced Practice Nurses. This was Denise Bryant-Lacosia's team, also from McMaster. In 2005, the Ibm Mcmaster Survey was adapted and mailed out to 77 eligible APNs working in oncology. The purpose of this survey was to examine oncology APN roles, processes, and outcomes. 61 items, and they were reviewed for content validity only. It wasn't until 2010 when the NP Practice Pattern Survey work moved out of Ontario. And at that time, the Ibm Mcmaster, the original survey, the Oncology APN surveys were adapted and refined by Dr. Ibm Mcmaster at Dalhousie to identify and focus on the direct patient care activities of NPs in Nova Scotia. It also included consultation, referrals, and implementation barriers and facilitators. This survey was also evaluated for content validity. Since that time, since 2010, there have been several other provincial adaptations. As you can see, the survey moved out of Ontario and was completed in BC next by Dr. Sangster Gormley, and then in Alberta, Saskatchewan, and Manitoba. That was Elsie Duff and myself. And then also in New Brunswick, which was Sharon Hamilton and Tracy Rickard. So it's been used extensively across the country now, and we are looking at, I just had a conversation actually with Terry Keane out of UPEI to administer the service, to administer the survey in PEI as well. Here are the results of what we've been able to accomplish with those surveys. So you can see that the Ontario Oncology APNs, there were 79 potential respondents, 77 participated, excellent participation response. And you can see the same for Alberta, Manitoba, Saskatchewan, New Brunswick, BC, and we're not sure what the original population was in Nova Scotia at the time in 2010, but we were thinking that it's not that much higher. I think it was in the mid-50s. So what we did as a group is we looked at all of the surveys. So we looked at every item, from the IBM survey to the Oncology APN survey to all of the items that we used in the various provinces to come up with, to look for consistencies and to talk about what do we still need in terms of these items and what new items do we need given the new context for nurse practitioners. And we identified several challenges with the approach that we've taken so far to NP workforce data collection. And these challenges were also identified in the scoping review and the discussion of the 2015 Research Agenda Roundtable out of the Journal of the American Association of Nurse Practitioners as well. There's inconsistencies. There's limited to no psychometric testing of these measures. We have small samples. It can be repetitive, and comparisons are difficult. The other challenge that I was thinking about this morning is there's limited access, maybe this speaks to repetitiveness, is there's limited access for nurse researchers who want to investigate NP workforce data collections. We sort of have to keep repeating the wheel. We can't have access to each other's data. There's no national sharing data agreement. So that leads to nurse practitioners being oversampled and having to repeat responses to the same questions. The other thing is that we have no standardized process to do it in a timely manner, like something set up so that we're doing it every 2 years or every 3 years so that we can look for changes within our context. So here's what we found. We found some items of limited usefulness. So thinking back to the IBM study, which is now, how old would it be? It's getting very dated, given the changes that we've had. Even the 2010 study in Nova Scotia is becoming very dated in terms of the changes that we've had in practice for nurse practitioners in the country. And we had to ask ourselves an important question. Do I care? Do I care about this item anymore? So items of limited usefulness included concerns over liability. Even though there are still some concerns over NP liability, I think we've sort of beat this one to death. The other issue was the inclusion of the Meissner satisfaction scale. We've asked a lot of questions of nurse practitioners about their satisfaction, their practice to full scope, and their work environment supports. But really, what do we do with this information? Is it important to those people that we want to reach out to? The other thing was hours of work, overtime, unpaid time, salary. We felt that salary is now quite readily available in the public domain, so we can easily access that information without having to ask nurse practitioners about this component of their work. And continuing education support in terms of days paid, financial support. All of the surveys sort of indicate that NPs aren't satisfied with this. There is great variability, but again, we have to ask ourselves the question, what will we do with this data? Is it really important? What is it that we really care about in terms of items so that we can reduce the items in a national NP survey that will be manageable for the respondents that we're seeking information from. So we want to keep it to a reasonable length. And we really had to ask ourselves some questions about, well, do we really care about this data or not? So here's some items for consideration. Educational preparedness. Now this does go back to the IBM survey, and we're still discussing this component of the items because we need to know if NPs are feeling educationally prepared for the context that they're going out to practice in now. We seem to have added so much to the NP course load and the NP program over the last 5 to 7 years. And interestingly enough, I was at the NOMP conference where in the U.S. in Atlanta a couple weeks ago where they're moving to DNP. And, you know, they said it right. They said, you know, that they've moved past the master's degree there, and they've sort of outgrown the content of the master's degree given the scope of practice of nurse practitioners now and all that we have to cram into a master's degree. Is it really fair to students? So we're still thinking about what items might be necessary, and I'm hoping for some conversation at the end about what you think about that item for consideration. Facility admission and discharge. This can include hospital, long-term care, emergency room, because this is changing across the country as well. In Alberta, we don't have facility admission and discharge yet for nurse practitioners at the provincial level, but we do have it at the federal level, and I know that they're moving forward with it in Ontario. So this will be important to add to any new standardized national survey. Home visits. NPs in Alberta do a lot of home visits, and we do primary care visits, so this is contextually for me, and I know that in other provinces they're doing it as well. You need to know why they're doing these home visits, what they're doing during these home visits. The other thing is CDF prescribing. And my colleague, Dr. Duff, and I have an article coming out from the Western data in terms of a model of factors that influence CDS prescribing for nurse practitioners. We really need to pay attention to this as a profession and identify not only what we are prescribing, but that leads to the next bullet. What are we doing in practice differently from other providers for the management of chronic pain and deprescribing particularly? The other two are frailty, which is up and coming, and we know that nurse practitioners deal with this a lot in their practice, and innovation. What are we doing that's different in our practices? So these are things that we think are items that we need to further consider for discussion in any national NP workforce data survey. Here's the conversation in the U.S. that I was talking about, and really they're struggling with the same issues. Even though they have a significant number of nurse practitioners, over 300,000 now I believe, there is still a general consensus among workforce experts that rich sources of NP data exist. Same with us. You know, we have these rich sources in terms of our provincial regulators, in terms of CCR&R, in terms of the CIHI data, but there is a challenge that includes a national lack of data as a source for studying NP workforce and outcomes, and the inability to identify individual NP providers within existing data and variations in how different sources of data are collected. So they're dealing with the same sorts of challenges there on a larger basis. And really I hope this is the start of a discussion for how we can move forward with not only a national survey, but also a national database for NP workforce data that will be readily accessible to three important audiences. The first being patients, the second being decision makers, and the third being data sharing between nurse practitioner researchers who want to identify different components of this data to study so that we don't have to ask the questions over and over again, but we can have some data sharing agreements that allow us to go into a large data bank where we can look and make comparisons across jurisdictions, across different practices. It would just make things so much easier. So where do we go from here? 5 sort of bullet points in terms of where we need to go. What is the future? I think we need to move past satisfaction. And I think that on all fronts, but particularly the satisfaction of nurse practitioners with their work environment and their practice. I mean, are we going to be able to influence that as researchers? Probably not. Limit the professional focus. So to date, there's been a significant focus on the professional data out of the NP workforce subjectivity that really it's nice for us to know as a profession, but how is it going to influence the other audiences that we're hoping to impact? We need to create a data set that is meaningful to patients and decision makers, identify opportunities for advancing the profession, and remove and limit redundancies that I've been talking about. So given that nurse practitioner patterns reflect professional standards that influence role implementation, educational requirements, practice performance, and patient care, we need to have a clear understanding of what NPs do in practice and how these activities influence patient, organizational, and system outputs and outcomes. So I'm posing the question to you today as educators, what NP workforce data do you need to inform the most up-to-date and influential NP curriculum? And I'm going to end there and take questions, and we'll continue the webinar as more of a discussion-based approach. Silence.
No, Tammy, it's Kathleen. I'll start off with a question here. Okay.
Okay.
So this is something we have discussed in our NP educators meetings or teleconferences, and that is there's a perception that we have a different group of students now coming into NP programs. They are coming in earlier in their practice as a registered nurse than what we might have seen 10 years ago or 20 years ago. And I'm wondering if there's been any discussion amongst your group about including data on years of experience or type of experience when coming into an NP program, so we could actually see if this is a trend that we think we're seeing.
Hi, thanks for that question, Kathleen. We do have that in our demographics section of the questionnaire, of the survey, in terms of what is your educational background, how many years have you been practicing as a registered nurse, how many years have you been practicing as an NP, what is your age in years, what is your gender, and we are, from the Western Canada data, what we saw, particularly in Alberta, just thinking about examples of, how this data could influence decision makers, is that we have an aging workforce here. So we have NPs who have been registered nurses for a longer period of time, and this is just speaking current, like the 2016 data, the most recent data that was surveyed. We have an older population of nurse practitioners who have been in practice over 10 years. And when I discuss that information with decision makers, I talk about the need for a strategy in Alberta for not only retention, but fulfilling the needs that are going to come in the future, because those NPs will be retiring. And I think what the survey data could examine, as you suggest, is how is that demographic changing? But unless we, have some way of comparing between provinces and have some consistent manner of sampling this type of information, which isn't being sampled through the other sources that I recommended, it will be hard to discuss this in the future.
Mm-hmm. Yes, and I think that it, the type of student that we get in is going to be very important for us as educators in terms of curriculum planning. So thank you, Tammy. Are there other questions?
You.
Oh, so go ahead. Oh, I see someone is typing.
I see Sharon's typing. I don't know if they can.
Oh, there it is. Yeah.
Yes, we certainly need outcome data in regard to specific common disease processes. We also need much more data surrounding research specific to NP practice. I agree, Sharon, and the question that I get in Alberta most commonly is, it works in other jurisdictions, but does it work here? And we are the most sampled, most studied profession in healthcare. Years ago, it was 50 RCTs of nurse practitioner practice. I think what we need, though, is we need a different approach in terms of the outcome indicators that we're identifying. And we need to have more discussions and more development of research projects with the decision makers on board from the very beginning so that we understand what their knowledge needs are, particularly in terms of patient knowledge of the role. One of the questions that was examined, and is, I believe it's still on our long list here, is community knowledge, or NP perception of community knowledge of the role, which seems to be very low. So I think we need to think carefully about the outcomes that we're going to measure, but we also need to think very strategically about which knowledge translation processes we will use in the future to get this information out to stakeholders so that they have a better understanding of what nurse practitioners do, because here in Alberta it was only 11% to any degree of satisfaction that NPs believed their community had knowledge of the role. The same results were similar for NPs' perceptions of physician and other team members' knowledge of the role and their manager's knowledge of the role.
Good, and we have someone else typing. Yes, Catherine. Tammy, Kathleen here again, just while we're waiting for Catherine's comments. I know your interest in interprofessional care, and certainly interprofessional care is important when we're working with complex populations of patients and clients. And I'm wondering what data needs your group has discussed in terms of understanding interprofessional practice in NP practice in Canada.
Excellent, and we have kept that on the forefront. It's always top of mind. And questions from previous surveys have been decided to be kept for inclusion in terms of identifying which interprofessional members are included in the teams which NPs practice on, which interprofessional members NPs collaborate with, including a long list of choices. And we also look at referrals back and forth from one provider to another in terms of who's referring to nurse practitioners and who nurse practitioners are referring to. So we have kept a large piece of interprofessional practice in the current survey.
Thank you.
Any suggestions from the group how we could improve upon that from an educational standpoint? You know, what information do you need in terms of IP practice to make stronger linkages between what NPs are doing in practice and between the education that they're receiving? I see Catherine has
yes,
something here.
Catherine has a comment up. Yes.
Family-based, many of your graduates take position in acute care and some in rural remote care. Data with regards to these various practice environments would be helpful. The curriculum is very full, as you already know, so we'd like some NP acute care data. And we do ask that question in terms of what setting they practice in, Catherine, and you can make connections between their practice and the activities that they perform based on the survey tool that is in development. To provide you an example of this, when we look at the CDF prescribing model that was recently developed and is being presented in the Journal of Clinical Nursing shortly, seems to have been a long process, but is that NPs who practice in acute care facilities were prescribing more controlled drugs and substances. NPs who practice with patients who have musculoskeletal injury and illness were performing more CDF prescribing. And NPs who were practicing with a pharmacist as part of their team, that actually influenced their CDF prescribing. So there's lots to be said from the current survey, the way that it exists, where you could make connections. I think that's why it's going to be so important for this to be published, Catherine, in terms of the standardized survey, and that we're all using similar items so that we can make larger comparisons, and we're sort of not doing these one-off provincial things, but we have this large set of data that will give us more power in our analysis. I hope that answered your question, Catherine.
And we have another comment from Sharon, Tammy.
Yes, students need to have opportunities to work with stakeholders in the community as well as interdisciplinary teams. Our curriculum should include these opportunities so that students understand their role. Includes research, yes. I couldn't agree more, Sharon. What we found in the results of the Western Canada survey is that most of NP's time, and it does come out in the survey because we asked them a percentage of hours, most of NP's time in these provinces is spent on clinical activities, and very little of their time is spent on research, teaching/mentorship, or leading system change initiatives. And it's easy to see that we are not really being able to enact our full role as advanced practice nurses the way that it's been conceptualized in theoretical models such as the strong model of practice in the Canadian context. And I'm not sure what we can do about that, but certainly the survey as we have it now, as you know, is sensitive enough to pick up those challenges. Thanks, Sharon. Any other questions?
Tammy, Kathleen here again, and I'll pose a question to you. How does your research group envision the best way to get a national survey out on a regular basis? Would you see this going through the licensing bodies, associations? What kind of discussion has been taking place there so that we could access as many NPs as possible for this type of national survey?
Well, the sampling process that we use in Alberta, which is similar to sampling processes in other jurisdictions, has been, of course, to engage the regulators in sending out the survey to anybody who agrees to receive research-related communication. We also, in Alberta, have the advantage of having one major employer, Alberta Health Services, which I believe Ontario is also going to Ontario Health now, so that may condense things a bit in that province. And the other was professional organization. So we also sent the survey out through the Nurse Practitioner Association of Alberta. And I believe this multi-pronged approach led to improved response rate for Western Canada. Our first, I think our preliminary discussions really are surrounding a partnership with the regulator and having some formal way to administer the survey through the registering body in a regular time interval. And I don't know what, we haven't discussed what that time interval would be yet, but potentially every 2 to 3 years so that we could start to recognize patterns. And we've also discussed that we might not administer the survey, the whole survey, every time, but that we might focus on specific portions of the survey depending on what is going on within the country at the time. Because certainly different things become contextually relevant as the profession evolves.
Mm-hmm.
So definitely a partnership with the regulators, but I'd like to see it more than just that, because I think if we have a multi-pronged approach, we will gain higher response rates.
Right. Great, thank you. Sharon has asked, so survey questions would be revised.
Yeah, we're still in revision, Sharon, as you know, but we could have pockets, right? Because you know the way that the survey is currently set up, we have different sections in the survey. So we might choose different components of the survey to be administered. So there'd always be a standard survey, but there may be different components of the survey that would enter into different years to as not have such a huge item burden on the NPs, right? So we might talk about interprofessional care, 1 year. We might talk about frailty another year, or we might talk about IP care and frailty in the same year, depending on what's going on within the context. Because as it stands, I think we still have quite a number of items within the survey which can become, quite burdensome to our respondents. I see Sharon's typing again.
Sharon typing, yeah. Waiting for her question or comment.
When you can't see or hear participants,
yeah, it is
in a world of your own, isn't it? It's like
it is.
Sitting here talking to the tree in my front yard.
Right. What would be a timeline that you would like to get a national survey up and going?
Well, I could see it within the next year, Kathleen. Certainly yeah, we've been doing a lot of work and it's coming together, but as we know, everybody has alternative commitments on their plate, so it's kind of taken backstage. But over the next 3 to 4 months, I'll be working on this to bring the group together again to make final decisions and get this publication out and look at where we can seek funding, because that's the other challenge that we have in terms of this type of work, is that who's going to fund it, who's interested, right? So we sort of have to make that case of, to CIHR or one of the large granting bodies that this needs to be done and what the value associated with that would be. I have engaged in discussions, though, with Compute Canada, and they are interested in providing significant in-kind electronic database service. So we need to be unified nationally, regulating, licensing, et cetera, to allow this to become more cohesive. I think it's the only way for the profession to grow and evolve. I agree, Sharon. One common voice, one common set of indicators so that we can improve the power of the profession through knowledge. Absolutely. Any others who'd like to, have a voice now about what you think might be important to you as educators in terms of a national database, national survey? What is it that you really want to know? What's your burning question? After graduates go out, what would you foresee as really important for you to know based on their practice, aside from what we've already discussed?
Well, Kathleen here, I'm going to pick up on Catherine's point that we have education programs that are focused on sectors of care, primary care, acute care. But my question going forward around NP practice is this: what will be relevant here in Canada? And Catherine has made the point that they have a family-based curriculum in BC, but many graduates take positions in acute care and rural remote care. So I think that information is very interesting for us as educators in terms of, do we prepare very focused NPs, or do we prepare NPs who are flexible and able to move around a symptom or a system of care into various sites and sectors? And I would be interested in hearing your thoughts on that, Tammy.
So do you think that goes back to these items for consideration, this educational preparedness piece that I mentioned earlier in the talk? Because we kind of, we've talked about it and we've kind of swayed. It's like, oh, well, what if we find out, educational preparedness and this is not good, right? As educators, it's like, oh no, what are we doing wrong? So what would it be about that educational preparedness we would want to know? Are we preparing them as a generalist? Do they feel prepared to take on their current role? And we can make some comparisons as to what role they're stating that they're in right now. So I think that's good. That's great to hear that educators would want that, because we were unsure in terms of how we would use that information and what it might say to stakeholders if they said they're not educationally prepared.
Well, I think it is an important question, and we do now know that the CCR&R is looking at licensure in the country. So I think it's an important question for us as educators. What kind of NP do we need to educate for the future?
Yeah, so here's just to give the group some examples. We do have an education preparedness section, and the item reads like this right now. Thinking back to when you first started practicing as an NP, did you feel educationally prepared? And that's a yes or no, so it's a dichotomic answer. If no, currently, do you feel educationally prepared for the role you have taken on? So there's two different items there. And if no, what are some of your concerns? And we have some choices for them. And then we have how can some of these concerns be addressed? So, what are their recommendations for the educational program? So we currently have those 4 items under education preparedness. And I'd love to hear, from those on the call later, if you have examples or if you have other items that you would like to throw into the pot for consideration, please feel free to email me. So, and I see that Sharon's in New Brunswick. People seem to be against the DNP. What about where you are? What is the consensus? I think, the consensus here, the context that we're in, and Kathleen can probably speak to this as well, is that the DNP is frowned upon. It's not something that the University of Alberta, I believe, is going to move forward with in the near future. But having been to the conference in the U.S. with the DNP by 2025, I'm not convinced that the U.S. isn't on the right track, given all that we have to squeeze into a master's program now. And that's it, right? We are squeezing so much into a master's graduate program, and I really think we've outgrown it. And the argument is that, well, if you're preparing a DNP, you don't have a PhD NP to, engage in education. You're taking from that sort of pool. But the reality is that some NPs won't engage in a PhD because it's not where their emphasis lies. Their emphasis lies in practice, not in research. Their emphasis lies in system change, not publishing results that may not influence practice for years to come. So I have an empathy for nurse practitioners who would like to get a doctorate degree but don't want to pursue the rigor or research intensiveness of a PhD, and we're not offering that at this point. So this one to come out with that is going to probably attract a lot of candidates.
Yeah. Yes, I know, Tammy, this has been discussed at CASN meetings in the past, and there is concern across the country around, the opening of DNP programs and what that would do to our PhD programs, and whether or not we have sufficient people interested in doctoral preparation of many different types that is going to sustain programs. So I think it's going to be an interesting debate in Canada going forward. So because we do have a lot of stuff to put in a master's curriculum. So.
Yeah, and it just keeps getting more and more. And Catherine raises a good question. How are MPs in practice incorporating scholarship into their practice? It's a real challenge, Catherine. And as I said, the results in Western Canada are they're not incorporating scholarship into their practice. I'd like to know more about why they're not. Anecdotally and qualitatively, I can tell you it's about, the system needs at the time. When an NP is brought into a practice, it's typically because access is lacking, and that's what they're there to do. They're there to improve clinical access. I think additionally, stakeholder knowledge about the role is that, we press so hard for the NP to be recognized as a clinician that we haven't been recognized for the additional scholarship that we bring to a practice, such as system change, knowledge of research, publications, mentoring of students, and that's the other piece, is that we're just not recognized for those components of our practice due to stakeholder knowledge. It will be important for us to bring those areas forward as we move the profession forward, because we bring so much more to the table, or maybe, similar things to a table as other professions emerge and evolve, such as the pharmacist, right? We need to make it clear in our statements about nurse practitioners that it's not just that we diagnose and prescribe and, read x-rays and whatnot, but we also are very important leaders that will have an impact on the system if we're allowed or approached for our input. But typically it doesn't happen in Western Canada from what I'm seeing.
Are there any further comments from our participants? Good.
So I'm glad I left time for discussion.
Yes. Tammy, I'm just wondering if you have any concluding comments for us here this morning.
Well, I think it was stated most explicitly in the first commentary from the review of the roundtable in the U.S. is that we really need to think strategically about a Canadian national comprehensive and accessible NP workforce database so that we can continue to study NP contributions to high-quality patient care and outcomes, and do so in a meaningful way so that we're not being repetitive, so we're not sampling the same nurse practitioners over and over again for different reasons, but that we have some standardized approach to this survey work, and that we have easy data sharing between researchers so that those with an interest or with a particular question in terms of NP workforce data can access that information easily and quite inexpensively without having to redo or reinvent the wheel each time. And I look forward to hearing from you. If you're on the line and you have other comments, or you'd like to chat about it off, as an offside conversation, I'd love to hear your comments.
Good, thank you. Well, Tammy, I'd really like to thank you for being our first webinar presenter for the CASN NP Educators Group. I think you've raised many questions, and you and your research group are doing some fabulous work that I think is going to be very informative for NP practice, but also for education and curriculum moving forward. So thank you so much for sharing this morning.
Thank you, and thanks to everybody who took time to dial in today.
Great.
Have a great afternoon, guys.
Yes, bye-bye.
Bye-bye.